exploratory topic, which is the endometriosis, deep endometriosis of the rectum and the sigmoid, and more specifically to try to identify indications for disc excision and for resection. So here you have my disclosure. So I have been involved in several master classes, workshops, webinars, clinical research by several companies, organized by several companies. But here I will present my own opinions. So you have to know that the rectum is a very particular segment of the digestive tract. It is the last part of the digestive tract, the last 15 centimeter. And it includes the rectal ampulla, which is about 9 to 11 centimeter length. And this ampulla is a very elastic organ, much more elastic than any other part of the digestive tract. It is a virtual cavity, which diameter may vary from 2 to 3 centimeter to 5 to 6 centimeter. And the volume may increase, you can see, from here, from this balloon, until to 400 milliliter of stools. So it has a very high compliance, and this compliance deserves because it ensures the protection of the anal sphincter against the high intracolonic pressures. And if you understand the function of the rectal ampulla, you come to realize that replacing the rectal ampulla by the sigmoid colon may lead to a low anterior rectal resection syndrome, and we'll see later what does it mean. So the rectum is not only a tube, it has an innervation, which is most important. So it has a parasympathetic and a sympathetic innervation coming from the inferior hypogastric plexus via the splanchnic nerves. And if the nerves are cut, the rectum will be only a tube and and we lose some of its measured properties of motility. Now, you have to know that the colorectal endometriosis is probably the most frequent type of deep severe endometriosis, because we are managing in France 1,400 cases a year. And among these cases, a quarter are managed in our center in Bordeaux. So the deep endometriosis of the rectum is a veritable marker of the volume of the surgical activity of a team. But to perform the surgery of the colorectal endometriosis, you need specific knowledge of the anatomy, but also of the function. So as you know, we have three techniques to treat the rectal endometriosis. The first is the shaving, where we carry out the excision of the nodule without opening the lumen. The disc excision, where we cut a patch of the wall and then we close the rectum, we suture the rectum. And the segmental resection, where we cut a segment of the rectum, including the disease. In my activity, I try to balance the use of these three techniques depending on the characteristic of each patient. And here you have my activity until the lockdown due to the COVID. There were 1,060 patients, and you can see that in 60% of cases I carried out shaving or disc excision, which are the conservative techniques, and in more than 1/3 of cases I however use the colorectal resection. So a balanced use of this technique is my belief. Now, the functional outcomes of the rectum are the major goal of the surgery, because they may have a huge impact on the postoperative quality of life. However, the functional outcomes were almost absent in the studies published before 2010. The rectal function depends on three major factors: the rectal shape, which will be influenced by the type of surgical procedure carried on the rectum, but also on the rectal innervation I presented you previously, and particularly on the possibility to carry out a nerve sparing during the surgery. And ultimately, the rectal function, postoperative rectal function, may be influenced by hidden preoperative functional troubles which were overlooked by the existence of the deep endometriosis. Now, no, I don't imagine that a surgeon can perform a colorectal surgery without being aware about the risk of LARS, which is the low anterior rectal resection syndrome. And the LARS is a mixture of symptoms which may result from rectal denervation, which leads to constipation, hypotonic rectum, major exoneration troubles, but also may be due to a rectosigmoid stenosis after the anastomosis of the rectum, leading to constipation dyschezia. May be due to the reduction of the rectal reservoir, meaning the resection of the rectal ampulla and the loss of the compliance of the rectum, with frequent bowel movements and urgency, and also may include the fecal incontinence, which is due to the resection of the ampulla. And as the LARS is multifactorial, it is very difficult it is challenging to avoid it completely after the surgery. And my colleagues from Aureus Medical Center, which is probably the biggest center of endometriosis in Scandinavian countries, they estimated that patients before the surgery with the colorectal endometriosis may present a major LARS score in 45% of cases. And after the surgery, a major LARS score may be found in 46% of cases, meaning that the surgery did not actually influence the number of patients who had, the percent of the patients who had symptoms of digestive symptoms, embarrassing digestive symptoms, meaning that the disease, but also the surgery, may be responsible for postoperative embarrassing symptoms. And to try to demonstrate that performing a conservative surgery is better than performing the radical surgery in terms of rectal function, I performed the first and the unique randomized trial comparing conservative techniques to radical techniques, to colorectal resection, with the goal to show that it's better to perform a disc excision. However, I was surprised to find that the functional outcomes were somewhat similar between the two arms, which means that the rectal shape, conserving the rectal shape, is not the unique factor which may impact the postoperative rectal function. I, however, identified that there is a higher risk of bowel stenosis after the colon resection, but the overall scores of quality of life were not statistically significant different. However, this trial was not useless because it demonstrated that the surgery of rectal endometriosis improves the symptoms in 60% of patients. 60% of patients have normal bowel movements after the surgery. And this improvement is constant because we assess it also 5 years after the surgery, with a very low rate of recurrences. And also this trial demonstrated that after the surgery, 80% of patients may have a pregnancy, and even 75% of them if they were infertile before the surgery. And the majority of them were pregnant naturally. So this trial ultimately demonstrated the surgery is a good treatment of infertility due to rectal endometriosis. Now, probably the outcomes would have been different if the randomized trial had focused only on low and mid rectum, meaning on the last 8 cm before the anal verge. But this difference in favorable to the disc excision, it has been demonstrated only in a retrospective study, including my own patients, where I observed that the LARS score is better in women who were managed by disc excision instead of colorectal resection for low rectal endometriosis. So I think that we have to modulate the results of my randomized trial. Now, performing disc excision or segmental resection probably does not impact on the risk of fistula. because anyway we have a suture and this suture may leak. And we observed that performing excision of the vagina and the rectum leads to fistula, particularly when the suture is on the low rectum, and that performing a stoma is probably not protective. Performing a stoma, a planned stoma, first-line stoma, does not protect against the fistula. So actually, we do not longer perform stoma in patients with low rectal resection or low disc excision. Now, I come back to the title of this presentation, so technique, what choice? I think from a functional point of view, any technique on the upper rectum and the sigmoid colon may be done with low risk of unfavorable functional outcomes. However, probably the problem is different on the low rectum, meaning at less than 8 to 10 centimeters above the anal verge, where, despite the result of my randomized trial, I propose and I recommend to perform disc excision instead of rectal dissection in order to conserve the shape and to reduce the loss of the rectal ampulla. So in these cases, we try to perform a disc excision instead of rectal resection each time the disc excision is feasible with a good anatomic result. To conclude, I would say that the surgery of bowel endometriosis is a new specialty. And I think that not all the surgeons should perform surgery for colorectal endometriosis just because there is a colleague, colorectal surgeon, available to cut and to suture the rectum. I think that the anatomy and the function of the rectum should be well known before starting the surgery. The minimally invasive approach is feasible in almost all the cases. And the major goal of the surgery should be the quality of life, because the patients undergoing this surgery are 30-year-old. So they have 50 to 60 years to live after your surgery. So the quality of life should be preserved. The conservative rectal surgery is feasible in the majority of cases. The immediate complications risk or comparable between disc excision and colorectal resection, and they are lower than after the shaving, which is not the object of my presentation. The functional outcomes are multifactorial, and probably the rectal shape is not the unique factor which impacts on the postoperative function, but anyway, it should be preserved each time if it is possible, by disc excision instead of segmental resection, while the recurrence risk, very likely it is lower with the segmental resection. However, there is no demonstrated benefit related to routine use of radical surgery, so I do not agree with surgeons who choose between the three techniques. It's a marker of individualized and custom-made management of colorectal endometriosis. And if you are available, and if COVID-19 allows, I will invite you to the Congress of the European Endometriosis League, the 6th European Endometriosis Congress in Bordeaux in June 2022. And I would be very pleased to receive you in Bordeaux and to speak about the surgery of colorectal endometriosis. Thank you very much.